roll.
Okay.
And I'm going to make sure that that's, yep. So we're in the process of recording. So last month we started this particular talk by simply just going back over the basics. We reviewed Seddon and Sunderland's classifications, tried to kind of draw home basic injury to nerve and then basic repair of nerve and how that correlates with what we see when we do a nerve conduction study and then what we see when we do an EMG. And so I just kind of want to go through similar things. And a lot of this is repetition. And then it's repetition in the context of different types of pathologies that you're going to see in practice. And so we'll go over a bunch of different examples of EMG and nerve conduction findings given specific types of conditions. So what's the aim of the electrodiagnostic study? We're looking for what's normal, what's abnormal, where's the problem, and then characterize it. Characterize it based on, people are joining. We should have given folks another 8 minutes.
Maybe so.
Characterize it on what type of involvement there is. Is it demyelination? Is it axon loss? And how significant is it? How severe is it? Because at the end of the day, what we want to be able to provide to our referring providers and to the patient and to ourselves is this condition going to improve? And I know that Dr. Lugo spent some time last week talking about, well, how do we use the electrodiagnostic study to help us in our management of a patient? And so if we spend some time talking about prognosis and what it is that we might expect from an electrodiagnostic study, then it's going to make us a better clinician, and it's going to give us a better opportunity to dispose of our patients from treatment and referral in a more effective way. So what do we look for? And what are the things that we typically use EMG for? We're looking for compressive neuropathies. We're looking for diseases of nerve and muscle. I don't know if anybody has been involved before in looking and using for Botox injections, et cetera, for spasticity. And we know that EMG has a high degree of specificity. And really it says, this slide says moderate sensitivity, but EMG doesn't have very good sensitivity at all. So there's some nerve conduction studies that have much better sensitivities, but it's a good tool. Definitely more specific. Does everybody understand the difference between specificity and sensitivity?
I wouldn't mind a little bit of clarification on that. This is Kelly in Alaska. Because I think when we're trying to develop credibility, the value of the test, we need to be real clear that it's providing something of value.
Sure. Okay, so oftentimes when I ask students to please define sensitivity and specificity, the first thing I hear come out of therapists' mouths is spin and snout. And I have to laugh and say, okay, good. No. Sensitivity is a proportion of tests that are positive when a condition is present. Okay, so if you look at a table for, can I draw? I don't know if I can draw. I need to. Hey, do you guys mind? Well, he's not doing it now. Okay, so I just found one part. Oh, here's annotate. Draw. All right. So here we have a box. this is the test, and this is the condition. And the condition is either going to be present or the condition is going to be absent. And the test is going to be positive or the test that we use is going to be negative. And actually it should be opposite. This is condition, this is test. But regardless. So sensitivity is the proportion of tests that are positive versus those that are negative when a condition is present. Okay? So it's A divided by A plus B. And that's all. So a test that is highly sensitive is one that you would expect that if a person has a condition that the test is going to be positive. So it's a good screening tool. So what's a good for carpal tunnel syndrome as an example? What are the most sensitive tests that we have electrodiagnostically for carpal tunnel? Do we know?
I'd say nerve conduction.
And nerve conduction.
What types of nerve conductions? So let's see. In a person who has carpal tunnel syndrome, is a median motor distal latency or is a short segment or comparison study more sensitive?
Median motor nerve?
No.
No?
Comparison?
Yep. Comparison studies or short segments have higher degrees of sensitivity. Now, when a person has a slow distal motor latency, then there's a more likelihood that the condition is there. A motor distal latency has high specificity. And so specificity is the proportion of tests that are negative, okay, when a condition is absent. So if we looked at D minus C over D, that's specificity. So a test that is specific when it's negative doesn't necessarily mean that the condition's not there.
Mm-hmm.
Okay? And the same thing with sensitivity. A test that is positive when something has a high level of sensitivity doesn't necessarily mean that the condition, or I'm sorry, if the test is negative when it's highly sensitive, it doesn't mean that the condition's not there. So a screening tool should be high level sensitivity because you want to catch things that are positive and you want something that's a screen to show up as positive, like a white count. If a person has an infection, then they may have a high white count, but it doesn't necessarily tell you what type of bacteria or problem they have. So a white count might be a highly sensitive test for some type of, say, staph as an infection. But just because the white count is high doesn't mean that the patient has staph. Does that make sense?
Yes.
So what does the whole concept of spin and snout mean?
I don't know.
Okay. This is where clinical practice, these tests get put into play. A test that has high sensitivity. When a test is employed that has a high level of sensitivity and that test is negative, then that generally rules out the presence of the condition. You need me to say that again? So a test that has high sensitivity that is negative generally rules out the presence of a condition. Okay? Conversely, a test that has high specificity, when that test is positive, that generally rules in the presence of that condition. So when a patient, if we know that needle EMG, as an example, is a highly specific test for radiculopathy, when we see fibs and positive waves in multiple muscles sharing a specific myotome, and we know that EMG is not highly sensitive, but it has high specificity, when we see abnormal EMG, the person has a problem. Okay?
Mm-hmm.
EMG is not highly sensitive. It is highly specific.
Dr. Brooks, you were saying something about short segment test. Can you tell me about that, please?
Sure. For nerve conduction, the most sensitive tests that we have for localization of a condition is a short segment or comparison study. So let's use a carpal tunnel as an example. The most sensitive studies for carpal tunnel are going to be short segment sensory motors or comparison studies. So a transcarpal latency, as an example, over 6 or 7 centimeters, or a comparative study between digits 1 of the median nerve in comparison to the radial nerve, or the ulnar nerve to digit 4 in comparison to the median nerve. When you see those studies versus a less sensitive test would be an 8 centimeter median motor distal latency, or the long segment, as an example, from the wrist to digit 3 of the median nerve. So the 14 centimeter segment. For instance, oftentimes you may see a digit 3 7 centimeter segment, 14 centimeter segment. So this is palm, that's wrist, right? Median sensory nerve to digit 3, antidromic. Everybody does that study, right? We've all learned it?
Yes.
Put an electrode on the finger, stimulate in
Yes.
the palm, then we stimulate at the wrist. Okay? Let's say that the palm to digit 3 latency is 1.4. And the 14 centimeter segment is 3.4. What's your norm for this 14 centimeter segment?
%, or oh,
No. What's your normative value for a
Value
14
for-
centimeter latency? Should be about 3.6.
Okay.
Okay?
Mm-hmm.
Or 39 milliseconds. Okay? Meters per second, I'm sorry. 3.6 milliseconds or 39 meters per second, typically. Something along those lines. Now, so is this normal or abnormal?
normal.
That's normal, isn't it? Okay. Now, but let's look at the transcarpal latency or the transcarpal velocity. What is the transcarpal latency in this particular segment? I stim in the palm, it's 1.4. I stim at the wrist, it's 3.4. What's the latency?
2.0.
Mm-hmm.
Yep.
over 7 centimeters, how fast is that?
Really fast.
Really fast?
35. You're doing math to get that. It's just,
Well, it's a 7 centimeter segment, and 7 divided by 2 is 35.
there you go. Yep.
Sorry, I picked the easy math, Kelly.
I appreciate it. I can see the work.
But what is the normal transcarpal velocity?
3.6, right?
No, a normal transcarpal velocity, the short segment, is 39.
Oh, that's, yeah, same as above. It
Yeah.
should be the same.
So is that fast or is that slow?
No.
Oh,
That's slow.
Yeah, it's slow. It's because it should be.
So can you see this in a patient that has very mild carpal tunnel?
yeah.
Yes.
Yes.
In fact, this is data that you would see in a patient with very mild carpal tunnel, where the long segment is normal. But when you do the short segment, Ganesh asked to explain short segment versus comparative studies. The short segment is slow. Patient complains of carpal tunnel, long segment's normal. We're obligated from the practice parameter to shorten the segment. When we do, we confirm the condition.
So this is a highly specific test.
No, it's more sensitive.
Sensitive test. But I thought it's, if the condition is present and the test is positive, it's specific, high specificity.
No.
Right. So we've just basically, I wouldn't say shot ourselves in the foot, but if you have if it's negative on the
long
14 centimeters or the 14 centimeters, it's negative, we would say, okay, it's negative, it rules out the condition. But if you go for the short segment and then it becomes positive, now we've got slightly higher specificity, right? I mean, because you're moving that up the notch. But now you can't.
We're increasing our sensitivity.
Sensitivity, okay.
Right. And now you can't rule it out as easily. It becomes more difficult, which is actually more accurate, most likely, right, to what you're actually aiming to get. You're ruling
Yes.
You're more likely, you can't rule it out as easily. In other words.
So with respect to a test that has high sensitivity, what if I give you this data set? Now, let's erase this, okay?
Hey, Dr. McKibben, real quick,
Yes.
I have a quick question on that. If you got this in a test and they were complaining of those symptoms, some carpal tunnel type symptoms, would you call that, and you didn't get anything else on your test except for that, would you call it mild median neuropathy at or about the wrist, or would you say very mild, or what would your?
I would say very mild.
Very mild. Okay, thank you.
Now, how do I get my pencil back? Draw. Hang on, guys.
The tool, it should be under the tool.
Where's the tools? Can you see what I'm selecting?
No, I cannot see what you're
Click my
selecting.
Can't see it right now.
I clicked draw. Maybe it's here it is. Okay. So let's take that data. So let's take the 1.4 data and the 3.4 data to D3. And then we go over what I would do in this case is go to digit 1. And if my median latency was 2.9, or let's call it 2.8, and my norm is less than 2.9, but my radial data was 2.2, what's the difference between those? 0.6. And up pops your red box of death because we want it to be less than 0.5. Okay. So here we have a transcarpal velocity of 35. There's a red box of death. And we have a comparison between the median and the radial nerve of 0.6, another red box of death. I'm calling that very mild median neuropathy at the wrist. So someone asked and confused sensitivity versus specificity. If a short segment, and we agree that a short segment study has high sensitivity, what if we did that D3 study and we saw the palm and the wrist? We see that the palm was 1.9 and the wrist was 3.5. What's the transcarpal latency? Or
2.6.
2.6?
1.6.
1.6, sorry.
Okay. And what's 70 divided by 1.6?
What's the 74?
7 centimeters.
Oh, okay, all right.
41 or 42? Isn't it?
43.
Oh, or 3. Is that normal or abnormal?
Normal.
That's normal. So here, if we take a look at just the wrist, from wrist to digit, in one case we had a patient with carpal tunnel that it was 3.4. We have another patient without that's 3.5. That test is not as sensitive, but the short segment has a higher degree of sensitivity. So in the condition of sensitivity, a test that has high sensitivity that is negative typically rules out the problem. So in this instance, is it likely that this person has carpal tunnel syndrome or has median neuropathy at the wrist?
No.
No.
No. Good. So, and by the way, you go with the very first person or the very first set of data that we saw where the transcarpal was 35 meters per second. We do a distal motor latency that's 3.8 meters per second. 3.8 in a test that has higher specificity, well, this is normal. That person still may have carpal tunnel. But if we see that that distal motor latency is 5.2 milliseconds, there's a big red box. A person with a median motor distal latency of 5.2 milliseconds, that is a highly specific test that is positive. Okay. A highly specific test that is positive helps to rule in the presence of the condition. Does that make sense?
Mm-hmm.
Yes.
Mm-hmm.
So
Yes.
just because it's 3.8 doesn't mean they don't have the condition, but typically when we see that it's 5.2, I mean, unless the person's got severe demyelinating neuropathy in other segments, you see a distal motor latency that's 5.2, or unless they're really cold, you see a distal motor latency at 5.2. This is a person with median neuropathy at the wrist. So it's sort of important to understand the concepts of sensitivity and specificity. It will be big time part of your ECS exam.
Dr. McKibben?
Yep.
Actually, I want to make sure I understand that because I may have got confused. Did you say because it's not even close to the normative value, that 5.2, that makes it more specific, or did you say it was something else? Sorry.
No, the 5.2 doesn't have anything to do with specificity. The test does.
Because it's a motor?
Distal motor latency is not as sensitive a test for carpal tunnel. It has a higher degree of specificity.
Okay. Thank you.
Okay. So we kind of went over that a bit. That was good. Go back to my mouse. Got to get rid of the lines. Sorry. So when we formulate a plan, you guys often in your plan formulation, you're kind of given a preserve, right? And then you're sort of expected to follow the preserve. But as you advance in your specialty, you will find that it's important to formulate a plan based on the way that the patient presents. Electrodiagnosis is an extension of your physical examination. And so it's also, in my next week, we're going to redo a webinar that I'd done some time ago where we talk about the living, breathing algorithm of electrodiagnostic tests. So we'll go through some of what we see this evening, and we'll kind of expand on that a little bit, and we'll just talk about some pearls and things that are important as you test. Because if you just use the same cookie cutter approach to test, you'll get most stuff with that cookie cutter approach, but you're going to miss things if you're not willing to change what you're doing, particularly based on how your patient presents. So it's important to understand where we start, and where we start is based on the way that the patient presents. We test nerves that we suspect would be involved and muscles that we expect to be involved. And just as importantly, we need to check nerves that we would otherwise expect to be normal and muscles that we would expect to be normal. We analyze that data on the fly, and we change our direction dependent upon the response that the data gives us. And all of those things we do to be able to answer the clinical question as to why they're there. Then we take a look, and you guys, Josh, I think you asked, so would I call that very mild or mild? And it doesn't, the concepts of very mild to very severe aren't so much to force you to beat yourself up, but there are latent traits in the things that we assess that help us to characterize the significance of a condition. And we follow a pattern, if you will, from very mild to very severe based on the presence of early demyelination. Oftentimes, early sensory changes are considered less significant than motor changes. And then as we begin to lose axons, things move a little more severe sensory-wise. And when we really start to lose motor axons, then things become more severe. So in the continuum from very mild to very severe, we sort of go from early mild demyelination to more significant demyelination conduction block to sensory axonopathy to motor axonopathy to very severe motor axonopathy. Does that make sense?
Yes.
Okay.
Yes, thank you.
So if I had to ask you, what is the best indicator for a good outcome in a patient condition? What do you think it would be? Of all of the things that we look at, what's the most important predictor or the best predictor of whether or not a patient's going to get better or not?
Whether they have axon loss or not?
Okay.
The EMG? Or
Josh said EMG changes.
Yeah, for
You guys agree with that?
Yeah.
Yes.
The question is, that has to do with the greatest likelihood of progress.
The best opportunity to recover, the best
Yeah.
prognosis.
It also has to do with how far the issue of how far the muscle is away from the identified loss of the axon.
Of all of the parameters that we have here, sensory nerve conduction, motor nerve conduction, snap amplitude, CMAP amplitude, or EMG changes, what is the best indicator for prognosis of recovery? Josh said EMG. Anybody say anything different?
Yeah, I'm going to stay with Josh if I'm wrong, and I'm going to go with Mark if I'm right.
I would say EMG because it deals with whether or not they have axonal loss.
Okay. Does anything else implicate the presence or absence of axons?
Snaps and CMAPs.
Yes.
Okay. And of snaps or CMAPs, presence or absence, which is more significant?
CMAPs.
Yes.
Okay. Do you ever see normal CMAPs and positive EMG changes?
You can.
You will. What if you get no motor response in a nerve? What if the APB is gone and you do a median motor conduction and there's nothing there distal to the lesion?
I would go proximal.
No. Well, if it's distal to the lesion and not there, do you think you're going to see it if you go proximal?
Probably not. I'm just trying.
No, don't say probably not. I need you to be confident. If you see a response distal to the lesion that's big and you go proximal to the lesion and it goes away, what's that called?
Conduction block.
And is that a good prognosis or a not good prognosis?
Good prognosis.
So if you're distal to the lesion and you do a CMAP and it's gone,
yeah, it's
is that a good prognosis or a poor prognosis?
Poor.
So if every patient that comes into your clinic, you do a needle EMG and you see some fibs and you see some positive waves, are you going to tell them that they're of a poor prognosis?
I don't tell them anything.
Well, they come to you because they want to know if they're going to get better.
Right.
Especially if you're referring your patients to yourself and then you're treating them afterwards.
Sure.
I talk to my patients.
I haven't had much opportunity in a while.
My question was, if you see a patient that has positive EMG changes, do you think that they don't have an opportunity to recover?
No, I think they have an opportunity to recover. I just think it's one of the greater, I personally think it's one of the greater predictors for a poor prognosis than other things.
Do you think it's better than CMAP amplitude? I asked you if you measured a CMAP distal to the lesion and it was gone, would that be a good opportunity to get better or a bad opportunity to get better? And everybody collectively said bad.
Well, the only thing I would add would be like you still have to look at regrowth and also you have to look at timing.
I understand that. And when we talk about regrowth, what's necessary for an opportunity for things to regrow?
Axonal sprouting.
What does it take to have collateral axon sprouts?
Time.
Preserved axons.
Yeah.
So if we have no preserved axons distal to the lesion and we get no response, what's our opportunity to get better?
Oh, nothing. Right.
It's not as good, is it? And what tells us the presence of motor axons distal to the lesion? The presence of fibs and positive waves or a CMAP amplitude?
CMAP.
Okay. So I'm not arguing with anybody that the presence of EMG changes isn't significant. The question that I asked you is, what's the best predictor of prognosis? That we have an electrodiagnosis.
Going with CMAP now.
CMAP.
Distal CMAPs.
Okay, I'm pretty new. Tell me again what that means. The CMAP.
Will you tell me what a CMAP means, Dick?
I
Even
don't-
if you're new, you would have learned CMAP day one.
No, I don't remember.
He hasn't done any of the courses.
That's okay. So somebody help Dick. What does a CMAP represent?
Compound motor unit action potential.
Motor action potential. Motor
Okay, it's
action.
compound motor action potential. And what that means is that if you stimulate a motor nerve, then it is the compounded or the summative motor response that's being recorded under your recording electrode when you do a motor nerve conduction study.
Okay, I get you.
It's a CMAP. It's the amplitude of a motor nerve conduction study.
Okay.
A snap is the amplitude of the sensory nerve conduction study.
Okay. Yeah.
So typically, and the reason that I have these listed in the order, you can see my mouse, yes?
Mm-hmm.
So nerve conduction velocity deals typically with what type of condition?
Demyelination.
More myelin than axon presence, yes?
Mm-hmm.
Okay. Once we start to lose sensory axons, we call that, we see reductions in snap amplitudes as being representative of sensory axonopathy, right?
Yep.
Okay. And we typically see reductions in CMAP amplitude as being representative of what?
Motor axonopathy.
Axonopathy.
Correct.
Right. Motor.
Now, we've said, and Josh and Vicky have both been involved in this. When we do a CMAP and we say, let's pick the median nerve again, since we're just talking about that. I need to go to annotate, draw. We see a distal CMAP of 2.8 millivolts. And let's just make an argument that our normative value is 3. Is that normal or abnormal?
Abnormal.
Okay. So does this mean that there is a loss of axons?
Yes.
No.
No?
No. It doesn't mean. It increases our suspicion that there is a loss of axons.
Mhm.
But does it demonstrate that it's a loss of axons? Not necessarily. What is the most sensitive? Now, again, this isn't specific. What's the most sensitive tool that we have to detect axon loss?
EMG.
EMG.
Right. So when we see this guy, if we want to confirm or deny that, see, because 2.8 could just be a normal variant of normal.
Right.
A patient may have some volar collapse of the first CMC joint and have some atrophy of the APB and a low CMAP, but no denervation. We see that all the time. So what should we do to confirm or deny whether or not this 2.8 is representative of axon loss?
EMG.
EMG.
Exactly correct. Now, a person that has a 2.8 millivolt response when 3 is normal, does this person have a good opportunity to get better regardless of EMG changes or not?
Yes.
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 Okay. But what if this person had a 0.2 millivolt amplitude
On the CMAP.
on the CMAP?
Poor prognosis.
Good.
Yeah. So again, we fall, and what's the likelihood then? If we see 0.2, I mean, I could stick a needle in it just to see if I see anything, but I'm confident that at 0.2 millivolts is there axon loss.
Yes.
Yeah.
Yes.
Absolutely.
I better see EMG changes to confirm it. If I don't, then oh my, what's going on here?
So Dr. McKibben, the
Yeah.
0.2,
Uh-huh.
that's where I think someone alluded to this earlier. So that's kind of where we're saying if there's a 50% side-to-side loss of, difference, 50% side-to-side difference, that's where you start saying that your prognosis goes way down. Is that correct?
No.
Okay.
The point at which your prognosis begins to go down across the literature is in the 75 to 80% range.
Okay.
Of difference between the right and the left?
Of just loss. So whether you compare it to norm or compare it to the other side. But see, it wouldn't if I saw 11 millivolts on one side and I saw 5 millivolts on the other side, 5 millivolts is a lot of innervation.
Right.
In fact, 5 millivolts may grade normal. I'm certainly not going to say that 5 millivolts isn't going to get better. So the side-to-side comparison isn't as significant to me. The 75% of the lower limit of normal is a better indicator to me, not the side-to-side comparison.
And specifically 75 to 80% drop of CMAP.
Yes, distally. And that's important, distal to the lesion. And we'll go over some examples of that here in a minute, because this is important for you guys to understand.
Dr. McKibben, if you, sorry to add to that, on the side-to-side differences, when you see, like, for example, your 11 to 5, and I know that's not the greatest predictor, but is that something that might concern you, like it could be continuing to drop lower, like it might go to 4 to 3 at that point?
But what's important, if I see 5 and I see 11, and I'm recording off the APB. Is this for sure axon loss?
No, we don't know that.
How do I know?
You'd have to look at your EMG.
EMG.
Very good. Very good. I can't drive home that importance enough. Okay. We good here?
Yes, sir.
Yes.
Cool. This is kind of fun, isn't it?
It's helpful.
Only thing we're not able to retain everything.
No, but that's why, again, that's why I said before we started, Ganesh, I said, it's important that we go over it, and then we go over it again, and then we go over it again and again. And you have that commitment. And seriously, when we teach preparatory courses for sitting your board certifications, we go over it again. Okay.
Okay.
I got a cough. So this is a fairly new slide. It's I just finished doing a chapter in the latest edition of Sullivan and Schmidt's physical rehabilitation, and this is a sort of a conglomerate, if you will, of looking at nerve injuries, classification of severity, and what types of injuries a person might have, and what we might expect as the mechanism of recovery. How quickly should we expect them to recover, and what's the prognosis? And it's really pretty straightforward. So for those conditions that we identify as very mild, and again, we can all agree that the characteristics of severity take us from sensory demyelination to motor demyelination. We move into moderate when we begin to have sensory axonopathy, and we move into severes when we have more motor axonopathy, and very severe when we have very significant motor axonopathy. So when we take a look at nerve injury, again, very mild demyelination. As we begin to advance in demyelination, we move into mild. How do those things get better? They remyelinate. How long does it take for things to remyelinate? Pretty quick. If it's only very mild and you stop the advancement of the condition, what's the opportunity for the patient to get better? It's great. When we move into moderate, we have more advanced demyelination with mild axonopathy. We get some remyelination in collateral sprouts. Takes a little longer to get better, but if it's very mild, if we prune a few branches off a tree, the branches that are left are gonna sprout. And what's the opportunity to get better over time so long as we quit pruning? Excellent. Even in severe conditions where we have moderate axon loss, that is, even if we have 20, 30% of the axons gone, and we have 70% of the tree that's left, and we get a lot of collateral axon sprouts, that's a good opportunity that that person's gonna get better. But when we have profound axon loss, very severe axon loss, what happens is that it takes a long time for these things to get better. And as Vicki or whomever had mentioned, the further things are away, the longer it takes to get there, things become more guarded in the patient's opportunity to get better. Make sense?
Yep.
Yeah, I really like this slide, Dr. McKibben.
Good.
Will this be posted on?
It'll be posted here, and
Okay.
it's published in O'Sullivan and Schmidt's new textbook, chapter 5.
So you would say that's a very good textbook to have.
No, it's an entry-level PT textbook. It's not a very good textbook for electrodiagnosis. Only reason I put it in here is because I updated the chapter and I put this in there.
Okay.
But it's a good summary. I mean, you've got it right here.
Yeah.
So you can screenshot that while you got it right there if you want.
Good idea.
Hey, Dick, do you know how to use a snipping tool?
I'm not
Don't
sure
you
what.
put your camera down, Dick. You got a computer in front of you.
Well,
Hey, do you mind if we stop for just a second to show Dick how to do this?
Go ahead.
No,
Watch
not at
this.
all. Go ahead.
This will revolutionize your life, Dick. Seriously. All right, watch this. If I go down to start and in my search, I type in SNI, I see snipping tool.
oh, okay. Yeah.
If I click snipping tool, I can go right here and do that.
Ah.
And I can now save this as to whatever I want it to be.
Okay. Now, what about if I'm on a tablet? I'm an iPad.
You're
Same thing?
screwed. Take a picture of it. If you're on
I'm
a
not
tab,
I'm not on a desktop. I'm on a tablet.
you're more advanced than me. If
I'm
you're
on
on
an
a
iPad.
tablet, push the two buttons and take a picture of it.
Oh, that's
Yes.
right.
And then it goes to your photos. Okay. So any comments, discussion about this before we move on?
No, that's
Okay. So common compressive neuropathies. Of course, carpal tunnel syndrome, right? mimics what type of radiculopathy? So here we're talking about ruling things out. When we see a patient who presents with numbness and tingling in digits, 1 through 4, what are our things that we will need to rule out? Most likely, our competing diagnosis is radiculopathy or more proximal median neuropathy. Everybody understands the symptoms and the signs: decreased sensation, positive Tonell's, positive Phelan's, positive Durkin's compression. They may or may not have weakness in the APB in the thenar group, right? That's carpal tunnel as a picture. Now, you see a patient walk in with this picture. Just by looking at them, how significant do we think? We have an ellipse here where an APB used to be. How significant is this?
Very significant.
And do you think the prognosis in this patient is?
Guarded.
Got it.
Yep,
That's
at best.
4.
But that doesn't mean...
That looks like more arthritic than...
It definitely has a lot of CMC arthritis. But when you see this ellipse right here, there's no thenar muscle. This picture shows certainly lots of arthritis.
Certainly lots of arthritis, yeah.
Yes. But that right there is not a good sign. We want this to go this way. We don't want it to go inverted. So, distal motor latency, slow. Sensory latency, slow. Everything else that we test, normal. How significant is this patient? Now, this isn't this patient.
Right now,
That's not too significant.
Well, I didn't ask you to qualify it based on, I don't write and I'm sorry, I'm picking on you, Josh, because you've done these more than others, I think.
I think
If
that's Mark.
you sent
Yeah,
me a
it's
report
Mark.
that said not too significant,
Sorry, I may have missed the
Neuropathy at the
question. My apology. I was taking a picture of this as well.
give me a severity grade on this carpal tunnel, on this
Uh,
median neuropathy at the wrist.
Let's see. This is a median, so I would probably just classify it as mild. Mild,
Anybody have an argument about that?
mild median neuropathy at or about the wrist.
Anybody have any other suggestions?
Moderate.
Thank you.
Was there axonal loss too?
No, but moderate's not what drives axonal loss. If you look at the severity scales that you and I have that you've received from us.
Okay.
A distal motor latency that's 5.8 milliseconds is certainly more than 110% above the upper limit of normal.
Okay.
And that's going to push you into moderate. The other thing that'll push you into moderate is the snap amplitude being low, but this amplitude is, just above or right at 10 microvolts. So that is right at the limit of normal, almost low. But this kicker here is moderate. Okay, ulnar neuropathy at the elbow. Again, everybody understands numbness, tingling in the pinky, little finger, trouble clipping nails, turning a key, pain to the elbow, digits 4 and 5, hypothenar symptoms, possibly dorsum ulnar aspect of the hand, may have positive Tonell's at the elbow, may have positive flexion compression test at the elbow, may have weakness or atrophy in the ulnar intrinsics. And what are the ulnar extrinsics?
Ditch time minimum. ADM.
Nope, that's an ulnar intrinsic.
Flexor carpi ulnaris.
FCU. Okay. Anything else?
Profundus.
Yep, flex digitorum profundus. Very good. So here we have sort of an ulnar minus hand. This ulnar minus, atrophy in the FDI. Not that patient. But here we see 37 meters per second across the elbow. Below the lesion, is this CMAP normal or abnormal? In fact, even across the lesion, is this CMAP normal or abnormal?
Abnormal.
Okay. What is it in size? Just I'm looking at this one, it's just under 4 millivolts. If I look at this one, I go 2, 4, almost 5, 4.5. So this is lower limit of normal. This is sort of low, but it's slow across the elbow with an amplitude at the lower limit of normal. What about this? Is this normal or abnormal?
It looks pretty abnormal to me.
Yep. Yep. So this is going to be more advanced on the high moderate level, most likely. Depends on what we see when we stick the muscle as to whether or not we see motor axonopathy or not. But even still, giving this preservation here, if this ulnar neuropathy is taken care of, are they going to get better?
Yeah, it looks like it.
Mm-hmm. Why?
Because it's intact distally.
Beautiful.
Did I say it right?
Yes, you did. Because we have a preserved distal motor latency. Very good.
So what I mean, anatomically, what you're saying there is there's some kind of a disruption to the axons functioning at the level of the elbow near the cubital tunnel, but it doesn't seem to have affected distally yet. In other words, there isn't axonal death. There's just disruption, or there's something like a bruise, if you will, or something that's still.
Well, we know there's demyelination.
Right.
And we know that there's sensory axonopathy because the distal sensory response is low in amplitude. And we're not sure about the distal motor amplitude as to whether or not that's a lot or no motor axonopathy distally. So we need to stick a couple muscles.
Right.
But at the end of the day, on this day, we suspect, given that there's a 4.5 millivolt motor CMAP, that there's adequate preservation, that if we stop this problem now, they've got a great opportunity to get better.
So, okay. Hey, Dr. Rick.
Yep.
On the first graph, you know that because you're comparing your CMAP at the elbow to the wrist, and it's stronger. You're stronger at the wrist, so you know that.
No, Dick, I'm comparing this CMAP to normal.
Okay, that's to normal, not necessarily comparing it to the ones at the elbow.
What if, Dick, I tested across the elbow and this above elbow was a flat line? What would that implicate? What if I did this and I see this response? What's this mean?
Well, that there's I don't know, I guess that there's a fairly significant lesion at the elbow.
What's this called?
I'm not sure.
If we have a response distally and we go across the lesion and the amplitude drops, what do we call that?
Conduction block.
Conduction
correct.
block. Okay.
Yep. So if there's partial conduction block, which is what this is, is that a good thing? Do we still have a good prognosis?
Yes.
Yes.
Yep.
Yeah, because it's distally intact.
Yep.
Yeah.
So that's what you would see, you think? I mean, in a situation like that, where they're similar to what was on that prior page? It's just another scenario that you're describing?
It's just another scenario. I just
Okay.
threw in a what if.
Okay.
So here's my question: which muscles are you gonna needle to check it distally?
Well, if this is the ADM, typically I'm going to stick first the FDI. And if the FDI is abnormal, I'll skip the ADM and then I'll just go to the FDP. If the FDI is clean, then I stick the ADM. And if the ADM's clean, I don't even stick the FDP.
You don't mess with the FDP, yeah.
But I try to go most distal, most proximal.
Okay.
And then depending on the most distal, based on if the FDI is clean, then I'm going to the ADM. If the FDI is positive, I'm going to the FDP. That's me.
Hey, Dr. McKibben.
Yeah, man.
On this, if the person started experiencing these symptoms fairly recently, and you saw something like that, would you think that it's possible that maybe just the Wallerian degeneration hasn't had time to take place?
Yeah, and that's a really good point, because time is an important factor in all of this. So what you just mentioned, Josh, is very important. If you see this particular patient 7 days after their symptoms began versus 3 months after their symptoms began, what you may see shortly afterwards may be totally different. If remember that what we do is we're seeing a snapshot in time. So this condition at 7 days, in another week, could be this.
True, because of what's happening, depending on the nature.
Because of what's happening right here. Yep. Now, the other thing that is important is that what if this is 5 years old and the patient's already had decompression and they don't have any symptoms, but they still have weak. Let's make an assumption that we see this low amplitude, and this low amplitude. And the patient comes in and says, 5 years ago, I had my ulnar nerve decompressed at my elbow. I'm not really having any symptoms anymore, but I'm still weak in my hand. Am I going to get better?
No.
No.
Right. Good. Even though they've got a preserved distal CMAP that's better than 75%? No, they're not going to get better because all of the collateral axon sprouts have already happened.
Yeah, they've already got.
And what I've got's just what I got left.
Yeah.
Right?
Right.
Cool. So thanks for bringing that up, Josh, because time definitely is an important factor.
You're welcome.
Where's that Mark?
It's Mark.
Oh,
Yes,
sorry, Mark.
Mark, Dr. Rick.
Sorry.
We must sound the same. I'm good with it. If I make a mistake, though, please do refer to me as Josh, though.
No problem.
And I want to call you by the right name, though, Mark.
And for some reason, I'm not seeing everybody on my table list. There comes Josh is back now. Okay. All right. So maybe one more. And then we'll come back to this again. In fact, next week, let's just come back to this and keep going with this, okay? And then then my next things are going to be moving back into the living, breathing algorithm again.
You'll be back next week, though?
Yes, I actually do next week's too.
Okay, good.
Yep.
Good.
May I ask a question on the previous slide?
Sure.
So if we look just at the image on the left, conduction block is pretty much a demyelinating disorder. But then if we add in the reduction in amplitude on the right, does that now make it an axonal and demyelinating?
Well, let's see. So what I hear you saying, or at least I think I hear you saying, and we'll probably finish on this. If we went to the right side and we saw this, and this was 55, and this were 7 millivolts instead of 4, or let's just call that 8 instead of 4. Ask your question again.
Well, yes, compared to the contralateral side, it would be.
It would be what?
It would be axon loss.
Okay. Now, anybody want to challenge that? Is it axon loss? Josh?
Not sure. I would say probably.
Mark, is it axon loss?
Okay, so let me make sure I got this clear. You said on one side you're having 8 millivolts of
Yep.
amplitude, and what was the other side?
Well, 4.
4. Not necessarily. Once again, you have to look at the EMG to determine that
Ah.
for sure.
Oh, that's right.
That's right.
There's at least a 50% decrease in amplitude on it.
Okay.
It's likely, but we don't know that for sure, in my opinion.
That's correct. Remember that, how do we get these normative values?
From thousands of tests that people have done.
Okay. And then how are they derived? Anybody remember?
The tests themselves?
What's this signal mean?
Exceptions.
Except.
No. In statistical terms.
Oh, goodness.
Does that mean?
It's mean.
Mean. Plus or minus 5.
Mean, but it's actually at SD, standard
SD,
deviation.
standard
Sorry, I
deviation.
don't write very good with a mouse. So we get norms with a mean plus or minus 2 standard deviations. And so if I drew a Gaussian curve, a normative curve, and this is the mean, one standard deviation is going to be about here, plus or minus. And how much of the curve, that's not a very straight line, how much of the curve is within one standard deviation?
How much of the curve?
How much of the data falls within one standard deviation in a normal curve, normal bell-shaped curve?
75%.
About 45%.
About 40.
5.
Anybody want to look that up right quick?
I just said 50%.
I think it's around 67
I got closest.
without going over.
I
you
did go
went
over though.
I'm
I
doing
went over.
calculus as we're looking at it. I'm just kind of like, well,
So I guess Vicky won with 50 then.
No, you won with 75.
Okay.
So here's 2 standard deviations. How much falls within 2?
95%.
That's what I'm going with. 95.
You're saying two more? So in
Yep,
other words,
no, just 2 standard deviations. This is 1 standard deviation, plus or minus.
Oh, okay.
This
Plus or
is
minus.
2 standard deviations. And then 3, I think, is around 99 or 98. But what does that mean? What that means is that if we take a normative value and we apply it as absolute, if we use mean plus or minus standard deviation, we're going to be wrong 5 out of every 100 patients that we see. And to me, that's once a month. That's too many mistakes, isn't it? So in a normal population, I should see an abnormal response 5 times out of every 100 patients that I see. Shouldn't I? Normally.
Right.
So when we rely on normative data, we have to accept that normative data is based on a range based on a mean and a standard deviation, which accepts that people are going to fall into the tails. Normally.
Right. But that's when you do left-right comparison, because if they're going to be normal on one side, they're going to be normally deviated on the other, most likely.
Possibly.
But not always.
That's why we need to stick a muscle when we see that it falls outside of norm.
Right.
And when it's normal, does it mean that it's not axonopathy? Somebody say no.
Okay, no.
Because how many times are you going to see a patient that may have an 8 millivolt response and the other side's 10, and you stick a needle in it and you see positive sharp waves and fibrillations? Lots.
Right. But that would indicate there's still a lot spared. But that doesn't,
absolutely.
That part's good. But it doesn't mean there is not axonal damage.
That is correct.
When you write your report, you're still going to mention that there's axonal damage because of the presence.
Yep. And that's why the EMG is important.
Right. But in terms of prognosis, in that, maybe I'm taking it too far.
No, you're doing beautifully. That's exactly right. But in terms of prognosis, I love that.
Right, because your body, it's showing that your body is capable of healing. Now, you're still going to have that conversation. I would be right into talking to people about, what are they doing?
Yep.
That's happening that you're actually causing damage. Fortunately, your body's recovering from.
Yeah.
But still hurting yourself. So.
And let's talk about time. Here's what I say to patients when they say, so is my doctor going to decompress this or not? I say, I'm not sure. What have you tried? They say, well, I've tried splints and injections and they've not helped. Well, you've done conservative care, you've done PT, you've done injections, you've done splints, and you're here. Well, you can either try more of that, you've got some time, or you need to think of, if you've failed conservative care, you need to do something. Now, if the patient says, I haven't done anything, I haven't tried an injection, I haven't tried splinting, I haven't tried any therapy, and they've got this, but they've got a little axonopathy, I say you've got some time. And then I might teach them, here's how to test these muscles. By the way, they're strong. Here's how to self-test your APB. Here's how to self-test your FDI and your ADM. If you all of a sudden notice, I'm losing this muscle and I can't hold, there's a good chance that this 8 may become a 4. And if it becomes a 4, you need to do something about it. Right. Now, if this person walks in my clinic and they're a 2 and they're a 10 on the other side, and I stick their muscles and they're full of fibs and positive waves with reduced rapid fire recruitment, Am I going to tell them you've got a lot of time?
No.
No. So I just upped my urgency to get back to the hand surgeon. Look, this is significant. You need to do something about this, and you need to do something about this pretty soon. Because if 2 becomes 0.5, guess who might not be able to clip their toenails? Right?
Right.
Okay. Good. So is that helpful?
Mm-hmm.
Yes.
Great.
Dr. McKibben, I have a question.
Yep.
So how do we differentiate whether it's a compressive neuropathy or like diabetic peripheral neuropathy? The results, EMG, would that help to differentiate?
I'm not sure in lots of instances where you necessarily can. It depends on how the patients present. How is a person, first of all, are compressive, excuse me, I'm sorry, I got a call. Can't shake this up. In patients who have diabetic peripheral neuropathy, is it common for them to have compressive neuropathies?
Yeah, they can.
They can.
Yes. So how do we differentiate the presence or absence of a compressive neuropathy in a person with polyneuropathy? First of all, what's the goal of our test? And what do we, if we go all the way back to the beginning of this, what do we do our test for? We do it as an
Localization.
To rule in or rule out.
rule in, rule out. And we decide what to test based on what?
EMG?
No, we decide
No. Oh,
what to
decide.
test based
on the patient's symptoms.
on the patient's complaints. That's exactly
Complaints.
right. So say a patient comes into your clinic. This actually is a great question, Ganesh. I hope that we can follow it here. A person comes into your clinic and they've got numbness and tingling that's predominantly in their feet. And they tell you, I'm diabetic and I'm here because my feet burn at night when I'm sleeping. And you begin your test and you notice that they've got absent surals, low amplitude peroneal motor, slow tibial H or absent tibial H reflexes. And now we've got to go up to their upper extremity. And we test their median nerve. What's the likelihood that it's going to be slow across the carpal tunnel?
Highly.
High. Yes. And even if they have a slow median motor distal latency, are we going to jump out and say, look, you've got moderate median neuropathy at the wrist, you have carpal tunnel, and now this is a compressive neuropathy that needs to be decompressed?
No.
What do
No,
you think
'cause
about that?
there are no clinical symptoms of that.
Right. But do they have median neuropathy at the wrist?
Possibly.
Yes.
Yes. Okay. But do they have carpal tunnel syndrome?
No.
No.
Okay. So the next person comes in. The patient walks in and they've got this steppage type of gait pattern and they say, I'm severely diabetic. But man, at night when I sleep, my hands are on fire. And I wake up and I hold them over my head and I shake them and I beat them on the pillows and I run them under water to try to wake them up. And we do that same study and we see similar data. Are we going to change what it is that we have to say?
Yes.
Absolutely.
Yes.
Yep. Yep. And so I don't think, Ganesh, that our data tells us necessarily whether that patient has compressive neuropathy versus diabetes-related peripheral neuropathy. We're confirming the presence of focal involvement superimposed on a more diffuse problem. But we're correlating our findings and we're making a professional decision to organize our results in a way that expresses to whomever that here is a problem. And by the way, here's another problem. And hopefully we choose to say to that referring provider what's going to impact the disposition of the patient the best. And so I would have no problem encouraging that patient consider having decompression, because I see patients that have diabetes related neuropathy who have carpal tunnel and do great with decompression all the time. Did that help at all, Ganesh?
Absolutely, yes. Thank you so much.
Okay. And vice versa. I see patients that wind up coming into the clinic with cuts on their wrists and cuts on their elbows and cuts at their knees and cuts at their tarsal tunnels who say these never helped at all.
Mm-hmm.
Yep. Yeah.
But I see the same patients who have cuts on their wrists, cuts at their tarsal tunnels, and you ask them, when did you have carpal tunnel surgery done? 20 years ago. Did it help? Oh, God, yes, it's great. Now I'm only complaining of this burning in my feet. They'll say, and they'll even say, I'll say, did it help when you had that tarsal tunnel released? They'll say, oh, man, it was great. It helped a lot. So I think in diffuse processes, compressive lesions are common. I don't know that our test, based on the findings of our test, can help us to differentiate, but the clinical presentation is very important, and it's important for us to tease that out for how we choose to organize the data. That was a pretty, that was a great question, Ganesh. Thank you for that.
Thank you. Thank you. And sorry, I've been calling Dr. Brooks because you sound just like Dr. Brooks. So.
Oh, no, I'm much better looking than Mark. We're both, now, I don't think that Dr. Brooks has much of a Southern accent, but I've been accused that I sound like I'm from the South.
So,
it's almost offensive. I'm actually very proud of it. Okay, so guys, it has been an hour and a half since we've started.
Mm-hmm.
And we're going to pick up from here. Just remember that we ended on ulnar neuropathy. And next week you'll have me again. And then in a month, we'll start the next phase with respect to me. Was this helpful to you guys?
Absolutely.
Very much so.
Yes,
Thank you so much.
Yes, thank you.
Good deal. I'm going to stop the recording.
Okay.
And
see you next week.